Hello and welcome to today's episode of the Pediatric Consult. I'm Dr. Jill Schaffeld, your host for today, and I'm in the studio with Dr. Emily Johnson and Kristin Harmeyer, both from UC Health, from the Center for Developmental Disabilities at UC Health, specifically the Timothy Freeman, MD Center for Developmental Disabilities. So welcome to you both. We are today sharing a bonus episode to talk about transition of care from the pediatric office to the adult office for our patients. So welcome, Dr. Johnson and Kristin. We're happy to have you here. So before we get started into kind of the meat of what we're talking about today, if we could have you both, we'll start with Dr. Johnson. Tell us a little about yourself and just maybe where you trained, any clinical interests you have.
Yeah, so my name is Emily Johnson. I am a family physician. I specialize in the primary care for adults with intellectual and developmental disabilities. It's been a long-standing interest of mine that kind of grew out of my experience as a family member. I have multiple family members with Down syndrome. And so I knew going into medicine that that's what I was hoping to do and specialize in. Initially, I had thought I would do like developmental behavioral pediatrics, but as I saw the kind of gap in care in the adult space, I shifted to family medicine. Trained at the University of Colorado for medical school and Tacoma Family Medicine in Washington State, specifically to try to get that experience with adults with disabilities. And now I'm here doing just that.
Are you originally from this area?
No.
Oh, okay.
One of the few. Yeah.
Okay, gotcha. I was curious. I thought, if you trained out west, but we're happy to have you here. Thank you so much. And I love that you shared, because I do think it's such a unique niche to be in, is that transition of care, and we don't have enough of that. So thank you. I appreciate it. So, and Kristin Harmeyer, and I have mentioned a community navigator at UC Health. So we're very happy to have you here as well. If you want to tell us a little bit just kind of about your background and maybe what your job entails, or if there's any specific training you did to get here.
So actually my educational background is mostly in health and wellness. So I worked at an agency for almost 20 years supporting adults with disabilities in Hamilton County. And what I was very passionate about was the health and wellness of those folks. So I created a program, and my entire role was focused on improving health for everyone and hoping to improve their quality of life as well. And when I heard about the Freeman Center, I thought this was such an amazing place and they were doing such amazing work. And then they had this role open up where I would be connecting people to resources in the community that would help improve that overall quality of life. So things like support organizations in the community, social organizations in the community, dental, mental health, all of these kind of extra things that are outside the specific medical care, but that everybody really needs.
Super important.
Yeah.
Yeah. So wonderful. Well, I'm excited to get started. We have a team here, I think, that can share a lot with us today, so thank you. So just, delving into being a general pediatrician myself, having conversations with patients and their parents about transition of care, like, okay, now it's time to leave my practice, even though you've been with us 18, 20, 21 years sometimes, isn't always easy. So in this episode, I hope we can give these primary pediatricians some guidance on how and when and what specific things to think about to make those transitions easier. So we'll kind of jump right in. But the actual process of changing doctors, when we think about this, we can be as basic as saying walking into a room and talking to a family about, okay, it's time to transition. But really, I think it's helpful to also think of it in terms of your practice, for your practice to have a process and what goes into that. So I will actually leave this question open to either one of you, but is there specific things that you would recommend to do, or kind of maybe, I guess, just even how, being very basic, how to develop a process for our pediatric offices involving transition of care of these patients?
Yeah, so I think what we see from people is that there's a subset of people who come in and feel like they were shoved out, and that's not a great feeling for people. So what I've experience is that what really people want is that process and expectations in that transition. And usually it's recommended that this start as early as possible to kind of give people time to process, think about it, and understand what's coming for them. And so Got Transition is a website that has some great resources about creating this process and what to include and when to start. And I think in general, people should start earlier than what you even think. So from the Got Transition recommendations, it's starting somewhere around age 12 to 14, where you start kind of slowly dropping hints almost, kind of like slowly talking about like, hey, at some point this is going to be a thing. Let's start thinking about it, practicing skills that you'll need in the adult world in the clinic, and then probably even at that point saying, this is the specific age and time that we expect that you will find a new physician or a new practice, so that when that age and time comes, they're not surprised and saying, oh, you never told me about this,
Sure.
so you're now just kicking me out. And so usually when people have a bad experience, what I find is this disparity in expectations, or there's a huge gap in what they expect to happen versus what happens. And so the more we can close that gap in expectations, I think that really improves the experience, even if the end outcome is the exact same thing. Really just having those expectations for people is really important, and the earlier the better.
Yeah. I think that's a really good point, too, because oftentimes as our patients get older and age out of our practice, 12 to 14 might sound really early. Whether your practice has a policy that says, 18 is when they age out or 21 is when they age out. But a lot of our teenagers, hopefully they come in for their well checks yearly, right? But,
Yep.
I feel like they're not in the office all that often. And so having that conversation years ahead of time, although it seems so early, is important, like you said, just so it's not a surprise. I feel like oftentimes it's, they haven't been in a year and a half and they call and all of a sudden they're 21 and it's like, well, you're 21. Sorry,
Right.
we haven't seen you in a year and a half, right? So I think that's a very important thing to think about, is to start that conversation so early. Did you have?
I would add that this is also an empowering thing. Like, you're growing up and now you are going to have the opportunity to talk to your doctor on your own and share how you feel, and somebody else isn't doing it for you. So I don't know that it always has to have this lens that it's, oh no, this is coming and this is going to be a huge responsibility and a huge problem. It's like, you're growing up and now you can feel like you're in control of your health.
I love that. I love the comment, empowering and in control. And I think that's a great way to word it to our patients, and not, like you said, not a scary thing, not a, oh goodness, this is going to be hard to do and your parent's not going to be around. And you get to talk to your doctor. You get to tell them what's going on. And that's a great point. So thank you for sharing that. When we talk about timeline for transition, we talked about how to start, when to start early, mention over and over. I know I mentioned 2 ages already. I feel like 18 and 21 are probably your most common ages. But, are there certain times that it might not be the best time to transition, and maybe for certain groups of people? And could either of you speak to maybe specific situations that might entail that?
Yeah, I think in particular for people that are followed by multiple specialists or more complex or have more needs, either from a social or a medical perspective, making sure that they're kind of stable, everything is kind of going as smoothly as possible, and at the moment of transition is really important, because transition is a time frame just like a discharge from a hospital or other medical transitions that is an excellent opportunity for errors and things to get missed, things to get overlooked. Insurance might change. There's so many changes at one time that if people can be as kind of steady, stable in their medical problems as possible, it's going to set them up the best that we can. We've had a few people who kind of transitioned to us in like the midst of a crisis, and we, do our best to help manage that. But sometimes you're like, man, this person who's known this person for 15 years may be better equipped to be the one to support them through that. And then, having that opportunity to make a little bit of an exception in those types of circumstances can really be beneficial. Obviously, if you don't know how long that's going to last or what it's going to look like, it may just be a more direct conversation with the receiving physician. One of those opportunities where instead of just a transfer of a medical summary or records, that it's actually a phone call.
Absolutely.
If only we could do like joint appointments, which
Yes.
isn't really realistic, but some sort of direct communication rather than just a transfer of records in
Sure.
those types of circumstances.
From the person that has that established relationship with
Yep.
them and their families.
Exactly.
Yeah.
Exactly.
And we do have patients who we get information on them and it's very brief. And then we are the ones that are doing the digging to find
Yes.
out what's going on. And it would be great if the providers that are sending the information are like, you know what would be really helpful to know about this person? And it could be something medical, but it could also be something social.
Yes.
Or like something that is just very important to this person, culturally even. Like that stuff could really help us and make the transition experience for the patient better, which is the most important thing.
Definitely.
Yeah, that social stuff is what does not come through well in the medical record.
Sure.
For a variety of reasons. But I think that's where if there's something in particular, socially, culturally, communication-wise, having that direct communication is really helpful for us.
Yeah. So I think, we can talk about even just like how to find the right doctors for the patient, which may be something as simple as proximity, insurance coverage you mentioned. Maybe it's a family member who sees someone that they already have a relationship with that they can share, that they have a great relationship with a physician. But, it's interesting, as you guys just mentioned, what you did about sharing some of the social aspects of things. Oftentimes as these patients transition, I feel like I don't even know who they're going to go see. So having a process in place for those patients to say, or maybe I don't know who they're going to go see until there's just a request for records, and I might not ever see that. That may just be my medical records department just sending them off. So, maybe thinking about as an office developing a process that, when we get the request for transition for that patient to transition out of the office, maybe it's a note to the primary physician, this patient's transferring out to this doctor, any specifics to share, or which would be great, because I'm not sure that, and I feel like we do a pretty good job, but it's eye-opening even talking to you guys. To my office probably could improve on that as well, which is good to know. That's why we're here, right, to learn these things. So talking about specifics and transferring of actual healthcare information to the new provider, what would you say? We mentioned social being, a huge thing that doesn't always translate well in the records. But what would you say are the most important parts of the healthcare summary that you as the accepting physician would like to receive? Because I'm sure it's not every single office note.
I've gotten that many times.
You're like, I don't have time for that.
Yeah, and
The
it's
Cliff
really
Notes
hard
version,
to
please.
piece through and find what is the relevant one. I think some sort of summary, and obviously these types of summaries take a little bit more time, so it may be something to build into a process as well of at what point can we write this basic summary to transfer to people that goes over kind of the plan for really, whether it's system-based or problem-based, to just have that summary of a plan for each thing that's a couple sentences long. But also, especially for primary care, we're kind of the guide for the rest of the transition in a lot of ways. So when it comes to specialists, medical equipment, medications, social stuff, vaccines, we take over most of that and kind of have to drive the next steps of the process. And so the more we know what of that needs to transition, the better. For example, for specialists, it varies a whole lot depending on the specialty, the need, what the problem is, whether or not they need to transition, what age they need to transition, all of that kind of stuff. And so if there's a list of they follow X, Y, and Z specialists, this one needs to transition, cardiology will stay at Children's because they have
Sure.
adult congenital cardiology.
Yeah.
They see an endocrinologist for their thyroid. Well, adult primary care usually takes that over. So if there's just kind of a list of what needs to happen,
Yeah.
that I got that the other day and I was like, this is amazing.
Oh, yeah, sure.
Same thing with medical equipment. I think people forget about medical equipment, but obviously there's an order for that has to happen every year in specific documentation. And so it's surprising even how many of the patients don't really know what medical equipment they need and who orders it. It's often like, am I supposed to do this? Like, who's supposed to do this? And so if there's a list of like, oh, they have this G-tube, they have X, Y, and Z, diapers, gloves, whatever, and I'm the one that orders it, or the specialist orders it.
Right, or what home health care,
Yep.
Service orders it, or not orders it, but sends the orders for you to sign, right?
Exactly.
So that's great. So maybe even copies of those specific things is great.
Yeah.
And I want to add that we have been working with a lot with teams within Children's on this transition process, and we've uncovered a lot of things that were just, I think people didn't know. So, for example, multiple departments were sending us portable medical summaries, and we never received them. So we would have a new patient and no information, or our team would have to comb through the chart and see what information we could find. And then when I would talk to the teams, they would say, oh, I sent you this portable medical summary about this patient, and it was never, it's lost into the void of technology. So that's something that I also think is interesting. Like if a pediatrician or somebody is sending the information, but maybe making sure that the information is received, because I think technology is wonderful. It's got so many lovely benefits, but sometimes I think we just assume that it works the way it should.
Absolutely.
And it might not always do that. So that was I thought that was a very important thing that we uncovered when we were working with them. So now we have a different process where they send it directly to myself and our RN care manager to review, and then we will communicate with the team before it gets to the doctors, because the doctors do not have the capacity to review all of these things and go through them.
Yeah. So, one of the things that you just mentioned, you can definitely consider giving an actual physical copy of these things to the patients if it's something that is super important that you're concerned might not arrive. But what other situations would you recommend maybe an actual just phone call or, some direct communication with that accepting physician? Are there specific situations that you might recommend that in?
Yeah, I think kind of like we mentioned before, primarily those complex medical or social situations being the main time where it's really helpful to have that direct communication. You can figure it out on your own over time, but it certainly helps when somebody gives you a little bit of a heads up. I think that's most of it, and I think most people know kind of when it's complex enough to need that specific phone call.
Yeah, absolutely. Any additional things as we kind of move on in our talk for decision-making pearls for the patient, talking about things from guardianship to alternatives to guardianship? I know I'm transitioning a little bit here with what we were talking about. So I think we talked about kind of records and timing and things like that. But those are things that I would tell you as a general pediatrician, I feel like I have no idea about, is how to guide families when talking about those sorts of situations, about guardianship, about other alternatives, just maybe even setting expectations for them.
Yeah, I think, this part of the transition is developing and promoting independence and skills and in navigating the medical system, and that applies for patients with disabilities, patients without disabilities, the whole spectrum of people. And so part of that starting early is to help kind of promote that and kind of assess what type of support needs a person might have as they're making this transition. The GOT transition, as we mentioned before, has a lot of resources on like what skills people should be working on and kind of readiness assessments if you're wondering about their kind of navigation skills. It does not guide in terms of like who needs a guardian and who doesn't, which is a very complicated assessment. I will say historically, the norm was for people to just, with any sort of intellectual or developmental disability, get a guardian immediately upon turning 18, and that is very much not the standard.
I love Kristen's over there
anymore.
shaking her head. No, that does not need to happen. So that's great.
Schools, sometimes the pediatric health system kind of still push people toward transition, A lot of people kind of scare families in saying, like, oh, you must figure this out and assign a guardian by the time they turn 18 or you're never going to be able to do anything ever again. And that's really just not true. In fact, it's really better if you're not sure to not assign a guardian, because getting guardianship removed is a much more difficult process than getting it in place. And so it's one of those things where it's helpful to know people over time, but that you don't also have to rush into the decision, and knowing the alternatives and making sure people feel comfortable with, like, okay, I'm going to be able to communicate with their doctors. I'm going to be able to help make these big medical decisions, can allow them to take a little more time in the decision.
That's a great point. It's great for us to know that, because I think for parents as well as physicians, 18 seems like oh gosh, all of a sudden, here you go. It's such a big age and a big transition. So thank you for pointing out that it doesn't have to be an immediate and a sudden. And I think, Kristin, you probably have some more to share about that.
I would just add that I think this process is an objective thing, but it's usually presented very subjectively. So the person that's talking to the family may have their own personal opinions about guardianship. So when they are consulting with this family, talking with them, their personal feelings are coming through. And this, like, I feel like we really look at this as like, okay, these are the things that may limit somebody's ability to make their own decisions in healthcare, and maybe they do need a guardian or they do need some more involved decision-making assistance. But we also feel like you should present all of this stuff, all of the options together, and not necessarily guide people based on. And we have interacted with a lot of people, and they all have a lot of different opinions.
Sure.
And so
everybody's situation's different, right?
Mm-hmm.
So who actually makes typically that guardianship assessment?
There's multiple layers to, like, how somebody gets a guardian assigned, and there's different people involved. The form that you have to fill out, at least for the state of Ohio, can be filled out by a psychologist or by a physician, and there's not a lot of limits on who or what specialty or, like, who can fill that out. And it goes through kind of an assessment of their abilities that's honestly pretty surface level. Then that paperwork and some other paperwork will go to a judge in the court, and they have a lawyer and stuff to get it assigned. I think sometimes the feeling is, oh, I filled this paperwork out to the best of my ability, it's accurate information, and then the judge will decide whether or not this is an appropriate assignment of a guardian. But I think kind of the opposite also happens, where the judge is like, well, who am I going to overstep
They
this
know better
recommendation
than
of the physician? And so I think it is really important to consider ourselves as not necessarily a gatekeeper, but like somebody that's helping to try to preserve the rights and autonomy, if possible, of people with developmental disabilities when appropriate. And think about those alternatives, because when you have a guardian assigned, you really do lose all of your rights to decision-making in your life, and there's ways to help support that in a way that can preserve people's autonomy.
What a tough position for you guys to be in, because it sounds like you probably do a lot of these, and probably much more than any general pediatrician would ever do. So I think that just kind of brings me back to your point about take your time in doing this. So, it's not the second time you've met the patient and you don't have a good feeling for their skill levels, their family situation, and I'm making this huge decision that's going to affect the rest of their lives. So it's a
and
great
that does
point.
happen, where
Yes.
patients come in and it might be the first or second appointment, and they want this.
And I think even more important that we then go back and say, hey, that's why we're talking about better communication and better transition of care, to if you guys are in that position that you have all the information that would help you make the best decision for that patient. So.
And if you guys do have conversations, or you know that you've talked to families about, like, oh, we think guardianship may or may not be appropriate for this person, including that in the summary can be really helpful, because when they do come to us at appointment number 1 and are like, can you fill out this guardianship paperwork? We're like, man, I've met you for the first time. I know nothing about anything.
Yeah.
If there's some guidance one way or the other from the pediatrician, it can be really helpful for us as well.
Definitely. Thank you. So moving along, just any mention or just kind of talk about the differences in kind of the support systems that are available in the pediatric world versus the adult world? Just, I think, all sorts of things to navigate the actual specific differences, right, that occur.
Yeah, I think this is something that we run into a lot, where people are very used to the pediatric system, and then they come and it feels very abrupt when they have to navigate the rules and the requirements of the adult system, which just doesn't have the same support. Anywhere from something as simple as arrival time. Technically, UC Health has like a 5-minute arrival window, whereas like I believe Children's has a 30-minute arrival window. So that's a pretty different amount of time. And people can often feel, I think they almost take it personally, or like it's just not a great entry into the adult world when they arrive 10 minutes late or 20 minutes late, and you're like, no, sorry, you're going to have to be rescheduled.
Yeah.
And so giving people a heads up that that's going to be a big difference, especially when they're going to a new place. They've never been there before. They don't know where the check-in desk is, all this kind of stuff. Saying like, nope, you really got to arrive on time, or even if they've gotten a heads up that they may need to be rescheduled if they arrive late, at least it can lessen the reaction a little bit.
Definitely.
And then one thing in particular with kids with more complex needs who have relied a lot on child life or other support services and getting labs, procedures, surgeries, anything like that done. As much as we would love to make that more robust in the adult world, it's not right now.
You don't have adult life? No.
Unfortunately,
yeah.
Yeah.
That would be great. That would be great for
to.
all of us, I think. So,
yes.
Yeah. No, that makes perfect sense. They're used to that additional support, and so talking to them about those transitions as well and how those things will change and the different expectations.
And the support isn't just those kinds of supports, it's also the amount of time that staff can provide to these patients, like the level of social work. They have multi-level social work at Children's, and we don't have that in our clinic. So, I think we do a good job to try to provide what the patients need, but the level of interaction is not the same.
Yeah, it's a great reminder. So we talked about guardianship and decision-making, that the patient, once they come to you guys, is in charge unless it's otherwise indicated. And that, I can imagine that that's occasionally tough for parents as well as the patients to walk in and feel like, whoa, they're not ignoring me, but this is very focused on them, and they get to kind of do this more on their own than they probably ever have before. So
that's where the practice and setting expectations is as much for the parents as it is for the patients themselves, where transitioning more to the patient answering more questions, ideally scheduling appointments, communicating on MyChart or whatever EHR system, is not only to allow the patient to develop those skills, but also to transition the parents slowly out from being that main decision maker, because it truly does get pretty abruptly cut off at age 18 in terms of access to the health record, phone calls, communication, unless you sign the appropriate forms. And so the parents probably need just as much, if not more, expectation setting and preparedness than the patients.
Definitely. And then just to maybe mention a little bit about other life transitions that may take place. So maybe changes in school, going off to college, ways we as pediatricians can help support our patients in those transitions. Any little pearls or wisdom you have to share with us?
Yeah, so at least in the developmental disability world, this time period is referred to as falling off of a cliff, because there's this huge drop-off in supports and services, not only in the medical realm, but school. It's often when people are used to getting services and supports through the school system for their whole life, and then all of a sudden they're like, wait, I'm supposed to get a job or find a day program, apply for county services, do all of this stuff, and it all happens all exactly at the same time. And so counseling a little bit about what those other things look like. If you don't have a patient with a disability, it may look more like, transitioning to college, or what is the next step. But I think there's a little bit of that cliff for everyone. It just looks slightly different. And it really does have a pretty meaningful impact on their health, their mental health. And so I think it's a really important thing to ask them questions about, get a sense, and try to connect with appropriate services, whether it's like the Department of Developmental Disabilities, trying to get hooked up with Medicaid waivers or other developmental disability services, or just school and whatever's next in their life. It's easy in short appointments, I think, to not want to talk a lot about those things, but it's in this stage of life, I think, is very, very important.
Yeah, I agree. And I was thinking back to something, Kristin, you said earlier when you were talking about just your background and the other maybe super important, I would say health related, but not always specifically medical, things that you do. You know, you mentioned school, Dr. Johnson. You know, they have fans that come to school and do dental care. And, you know, it's wonderful because everything's in the same place. But I'm just now thinking, like you said, falling off that cliff, like all these things we had, you know, all these services provided just within the safety of our school day. And now it's do all of those things on your own. So
Well, and also
quite
you
mind-boggling when you think about it.
You also have so much social interaction at that stage in your life. And a lot of people, I think, again, like Dr. Johnson was saying, it's not just people with disabilities, but people who they had a lot of friends at school, and then those friends go off to college, and you're here, you're not at college, and you don't have a day program, or maybe you do, it's once or twice a week, but all of those activities that, you know, improved your daily living have gone away.
Absolutely.
So, and I think that, you know, college is a hard time. You know, some people have a great time, and that's great, and other people, it is a rough period. So
It'd be a scary time for sure. So, Dr. Johnson, you mentioned specifically about some developmental disabilities, the services. Would you like to discuss a little bit about maybe some specific services that are provided? And maybe this can be more locally or even nationally if you want to mention some things that we can kind of help with mentioning to our patients, or obviously you guys will know even more than we will, but just thinking about services that are available so that we can at least make our patients and families aware of these types of services.
Yeah, I think this is really important, and I wish that physicians had a little bit more knowledge about this area. So every state, the Medicaid system is contracted with the federal government to provide home and community-based services for adults with developmental disabilities through what are called Medicaid waivers. And every state is different on how you access those services, what services are available. And so, unfortunately, everyone in their own state has to familiarize themselves a little bit with that. But I think even just kind of knowing the term Medicaid waiver and guiding parents usually toward a county or a state board department of developmental disabilities is great, because there's a lot of waiting lists. It can take a long time to get hooked up with services. The documentation requirements are very specific and have to often be done before a certain age. And so I don't think it's ever too early to start like a broader future plan for an individual with a developmental disability, because at some point they're going to need support services outside of their own family, and those support services cost a ton of money. And so if you don't have that support through Medicaid, it's pretty cost prohibitive. Over the long run, that can be like residential services. Historically, it's been more group home based, but that's also transitioning more to like individualized supportive housing. That can look a lot of different ways, and that varies by state as well. Certainly, very few institutions remain, and that's definitely not the standard anymore. It can also be vocational support, day program services, respite care, certain supplies that aren't covered by insurance, and that all kind of comes through the same department, the same Medicaid system. And so guiding people toward getting into that system as early as possible, I think is great.
18 when they would be able to apply for that? So it sounds like that first step is really just applying for that Medicaid waiver.
Yep.
And they would do that at 18. So that's something that we could...
You can be connected to your county board in Ohio before 18.
Okay.
But you, I think, renew
Gotcha.
at that point.
Okay.
But
But definitely by 18,
Yes.
it sounds like. But that's
And
great
there's no
information
time
to-
that you can't, but it can be more complicated if you
Okay.
do it later in life because
Gotcha.
of their age limits and you have to prove records for things. But something else just to add is, again, when we're getting that information from pediatricians, if we know that they're connected to people who know them and know what resources they want. So when I go in and meet with patients at our clinic, I don't always know them. So to try to connect them to services that are going to improve their life is a little more difficult because I don't know what they like. So, I have to find out things that they like and try to make recommendations and provide them with resources. But if somebody who knows them is able to help give that information, it would be really valuable.
Definitely. No, that's
And one other thing that's important, I think, for pediatricians is eligibility for services requires documentation of a disability prior to the age of 22. So for people that kind of fall in this, like, mild, for lack of a better term, intellectual disability or autism that, like, aren't really obvious, maybe the diagnosis was made late, things like that, if you're at all concerned that they might need those support services from a disability perspective into their adulthood, having something in a psychological evaluation, things like that, documented prior to age 22 if it's not done by the school is actually very critical because they can lose the opportunity for, like, if you're diagnosed with autism at age 25, you're just not eligible.
Right. That's a great point. Thank you for sharing that. So I feel like I'm now circling back a little bit to the beginning, but one thing that I want to mention that Dr. Johnson, that you have been a great resource for was developing a letter that we can send to our patients, that pediatricians can send about transition of care. And it, I believe, includes just timing, but, some of touches on some of these things that we've discussed as well. And I believe that we will attach that to the episode, to the podcast episode today for our listeners, which is a great resource to share. And then the Got Transition website as well, which is wonderful. Any additional kind of wisdom to share? I know one thing that I'm kind of, as we're talking, thinking is, gosh, we should really have a set. These are maybe the 4 or 5 pearls we need to do as a practice, to have a true transition process, not just a time to transition, but there are multiple layers to this that I think can be super helpful to the physician that we are, transitioning care over to, and super helpful for the families as well. So any additional resources to share or, asks from us as pediatricians that may be helpful as we entrust our patients to your care?
I don't think so. I think that covers it. Like you said, the process is really helpful. Got Transition has a ton of stuff on developing a process. At least when I've seen it, it seems very overwhelming. So you might pick and choose a couple little pieces to try to implement. But setting expectations and having a good process is, I think, key.
And having those early talks.
Yep.
Yeah, definitely.
The only thing I would add is that, at least in the disability world, there are a lot of resources out there, but they can sometimes be really hard to find. So having a person, connecting with your county so those people know a lot more about the resources that are out there and they can provide more information can be really helpful than trying to find it on your own. Because it's my job and I'm always finding new things that have been around for years that I didn't even know about.
That's great.
Yeah.
Great to share. Thank you. Well, thank you, Dr. Johnson, and thank you, Kristin Harmeyer, for being here with us and sharing all your knowledge. And I think this was very helpful. And probably, we're calling this a bonus episode, but I think it's an interesting, it's not just one little medical topic. It's truly about a huge portion of our patients' lives. And I think this is such a helpful thing for us to hear about. So thank you for being here, and thank you for talking with us today.
Thank you.
Thanks for having us.